Thank you for your kind invitation, also to Professor Azam, who invited me to be here and to talk about DCB, which is my main scientific and technical point of interest. If you can upload the slide, yeah. So I would like to start from a quite clear concept, which is that the stents that we are using in our patients are not perfect, okay? This is the very long 10-year follow-up of patients treated in simple lesions or normal lesions, not complex lesions with two widely used DES and another one experimental, but there is no difference. So we have a 3.3% of acute events every year with that device after the first year. So when we implant a stent, we have adverse events which will go on for our patients. The other concept that I would like to start with is that when we implanted drug-eluting stent, actually we implanted drug-eluting stent for 1 year, because in terms of event, after 1 year, it is quite the same as a bare metal stent. So the concept is that after 1 year, metal is metal. And then if we go deeper into more complex lesion settings, in this case I'm showing you the small vessel disease, which is quite normal and typical here in Bangladesh, like in Pakistan, in India, and in many other countries. We can see that the adverse events, in this case with Zions, are double than in case of larger vessels. So in the complex setting, drug-eluting stent is not so perfect or very well performing as we are expecting. And then, on top of the complex lesions, we also have complex patients like the one that we have seen now with the live case. We have a lot of patients with a history of bleeding, valvulopathy, and then patients with reduced ejection fraction. So this is the setting where we are treating patients, okay? And we have to remind this. And then, if we have patients with multivessel disease, we put a stent and then another one, and in the end, we will have this thing with a chemin de fer, as we call it, with all of this metal which is percoring the patient's anatomy. If we use DCB, we may use a technology which better respects the anatomy of the vessel. We don't implant a scaffold unless we need it, but I will show you some cases where we don't need it, and there is a possibility of the flattening of the curve of the adverse events, because not implanting a stent, not implanting a scaffold, the adverse events will go down. This has been shown in several studies. Whereas if we implant metal, we strengthen the vessel, we may occlude side branch, and we put something that will never leave the patient. I'll be very fast for in-stent restenosis, okay? This is not my setting. In-stent restenosis has a clear indication for the use of DCB, as for the use of drug-eluting stent in Europe. It's a class 1 level of evidence A, okay? This is okay. My focus here is to tell you which is our experience on the use of drug-coated balloons in native vessel disease, and I'm going to show you one case that we did a few months ago with a diffuse disease, a highly calcific lesion in a proximal LAD, and then a total occlusion distally, diffuse disease. We hope that the proximal lesion of the LAD was not significant, but we did IFR, which was 0.82, so we had to treat it. But when we have calcium, we need to understand how is calcium. So in this specific case, we decided to do the OCT imaging showed a calcific nodule. So we decided to use IVL. Well, yes, this is a very expensive case, but the patient was young and it deserved this. IVL was not able to cross the lesion, okay? So if we would have put a stent there without understanding by physiology and then imaging how was that lesion, in this case, we could have created big damage for the patient. So we predilated the lesion, we did ROTA, 1.5 bore, and then we predilated again, and then in the end, we did intravascular lithotripsy in order to achieve a very good preparation of the lesion. This is very important if we want to use drug-coated balloons. This is very important if we want to use drug-eluting stent as well, obviously. So when we have prepared the lesion, we decide to put the final therapy, which is DCBs in the proximal LAD, in the mid LAD, and distally where we had that occlusion. And we used 3O balloon, 3O balloon, and 2O balloon by 20 in the distal part. So this is sort of full DCB PCI of the left system. We don't have a stent-like result, but we don't need a stent-like result, okay? We don't have a scaffold. We don't have to feed our eyes when we have done a DCB PCI. Because we have clinical data that I'm going to show you very soon, showing that if the result is like this, the patient will not come back. And this is another case of a patient done a few years ago with a total occlusion of the mid LAD. After this very large diagonal branch, we prepared the lesion. This was not a complex chronic total occlusion. So we prepared quite easily the lesion. Then we used a long drug-coated balloon, 2.5 by 40. This was the final result. You can clearly see that the final result is not a stent-like result, okay? But as I said before, we don't need it, because with some good drug-coated balloons, we may have a lumen enlargement after a few months from the implantation. And this is what happened in this patient. After 6 months, we had this very nice result with a lumen gain and with a late loss which was negative, okay? So the vessel was larger as the one that we left. This is something that is not happening when we use a drug-eluting stent. We also did, in this case, EOCT just to show the total healing of the dissection that we had left. Because this has been shown with paclitaxel coated balloon quite clearly, that if we use a good paclitaxel coated balloons, and we have some preliminary data also for sirolimus coated balloons, in the vast majority of the patient, the vessel will go increasing. And this has been shown by the German group and by our group as well. The other thing from this, over there. The other thing from this Japanese study is showing that the dissection index is correlated positively with the lumen enlargement, which means that if you leave a dissection which is not flow limiting, if you leave a type A or type B dissection, that vessel is going to increase more in the dimension instead of the cases where you don't leave a dissection after DCB angioplasty. And we have shown in this study, which was published 7 years ago, that if we leave a dissection, the vast majority of the dissection are healing. In this case, we had 3 cases of dissection not healed, 45 cases of healed dissections, and mostly important, no thrombotic case. Because the message is that any type of drug-coated balloon is safe. It may go with restenosis, like with drug-eluting stents, but it will never give you problems in terms of thrombotic events. And this is another case of another device that we used, which is the Elutax drug-coated balloons, which is showing a very good late lumen loss, 0.04 in a small vessel disease setting. In Piccoletto 2, we enroll patients with up to 2.75 millimeters of vessel diameters. And in this study, the drug-coated balloon did outperform Xience. So we expected non-inferiority, but we had superiority versus Xience. And this is quite the same with this other balloon, which is showing not differences as compared to drug-eluting stent in native vessel disease between 2.0 and 3 millimeters in this randomized clinical trial. And then we have the most modern technology with drug-coated balloons. I was mentioning it before during the live case. This is Magic Touch. Magic Touch is a sirolimus-coated balloon, the first one being marketed in Europe. And in this device, we have sirolimus, which is protected by a phospholipid bilayer, which is creating these nanospheres, which are put upon the inflation of the balloon into the vessel wall. And what is happening is that, like for other devices, this sirolimus is entering the vessel wall and is staying there for the following weeks, exerting its effects. We have shown a very good late lumen loss in a native case series of patients, native vessel disease, small vessel disease up to 3.0 with a late lumen loss of 0.09, which is better than any other type of drug-eluting stent in this lesion setting and vessel dimensions. After this, we decided to do a larger study, and we designed the EASTBOURNE registry, whose results have been presented during EuroPCR 1 month ago. And this is the largest study ever done with drug-coated balloon. We enrolled prospectively 2,123 patients. I want to tell you that this study is investigator-driven study. And we enroll patients from Europe, but also from a lot of Asiatic countries with good experience with drug-coated balloons. And this is the clinical follow-up in this all-comer population of patients with in-stent restenosis, native vessel disease, small vessels, also large vessels. The TLR rate is 6% after 1 year, all-comer population, 45% of patients with ACS. So TLR is 6%, MACE 9.2%, but you can see that the adverse events in terms of safety, which are total death and MI, are very low after 1 year. And interesting, the efficacy of Magic Touch is more pronounced in the native vessel disease setting. Because if we split in-stent restenosis versus native vessel disease, we can see that the TLR in the native vessel disease setting is very, very low, 2.5% after 1 year, with all of the events in this study which have been adjudicated by a CEC. And these are the main determinants of TLR after 12 months, which are, as you can see, previous PCI and ISR on top of diabetes. Okay, so if we treat ISR, DCB is less performing than if we treat with DCB native vessel disease. Okay, this is related to the fact that, as we know, TLR is something which is related to probably the first implantation of the stent, which is not perfect. So if we don't understand exactly which is the cause for TLR, and if we don't do intravascular imaging, also all of the other therapies that we are giving to the patient, DCB or drug-eluting stent, may fail. So we have to keep this in mind. If we prepare perfectly the lesion after ISR according to the findings of the intravascular imaging, the goal is done, because also there the events will be lower. And we will go analyzing this specific subgroup of patients in future publications of the EASTBOURNE registry. Which are the new limits? The new limits are the very complex patients where we don't have to forget about the efficacy of drug-eluting stents. So in these patients, we have to decide to prepare all of the lesion, to use drug-coated balloons for mid and distal vessels, and to use drug-eluting stents for the proximal vessels. This is the way to go in the complex patients. First thing. Second thing in the future is Transform 2. Transform 2 is another investigator-driven study that we are running, and we are enrolling patients comparing Magic Touch versus Xience in native vessel disease. So not only small vessel disease, but native vessel disease between 2.0 and 3 millimeters. So after we have prepared correctly the lesion, which is a mantra, it is so important, we will randomize patients to these two strategies, and we will see in 1,400 patients, so the largest randomized clinical trial on DCB, if there will be no differences in terms of TLF. We hypothesize non-inferiority for TLF, and we hypothesize the superiority for NACE, because as you know, with drug-coated balloon, we may reduce the total length of antiplatelet therapy as compared to drug-eluting stent. So this is the investigator steering committee that I'm coordinating for Transform 2. And I'm going to show you, to finish the last minute, with this case, which is another complex case of an 84-year-old lady with reduced ejection fraction, which came with ACS and heart failure at our hospital. So we stabilized the patient due to the heart failure, and then we brought her to the cath lab. This is what we found, a CTO of the RCA and a very diffusely disease of the LAD. In this patient with a history of bleeding in gastroenteric part, we decided to use a full DCB strategy. Also here, this is the circ that we decided to leave alone, and this is the spider view to see how aggressive was this. This is, I think, a typical Bangladesh patient. How aggressive is the atherosclerosis? So we decided to go for a full revascularization with DCB. We prepare all of the lesions with non-compliant or semi-compliant balloon. We also use one scoring balloon, and then we started using DCB for the diagonal branch, for the proximal LAD and the other diagonal branch, and then for the medial LAD. This is the final result, and this is the final result from the cranial view, which is a nice result. We don't need the stents here. And then a few days later, we decided also to attempt the CTO. We prepared the lesion, and then full DCB with magic touch, 3 magic touch, and this is the final result. With a good dissection, but we have learned that a good dissection is good for DCB because it will let the drug enter into the vessel wall. So if it's not flow limiting, you can stop. So my conclusions, current era drug-eluting stents are good, but they are not perfect, especially on the long term of our patients. DCB and specifically sirolimus magic touch DCB are a valid alternative to drug-eluting stent in some native vessel disease anatomical settings. So before paving the coronary arteries of your patient, just think at this possibility. In some specific settings, with a complex lesion settings, you may also decide to go for a hybrid approach with full DCB and then spot stenting. Thank you for your attention.